the webinar this afternoon. Today's webinar is on the topic protected TAVR, how to reduce your risk of stroke. And we're very excited to have some great speakers with us today. Today we're going to learn about about treatment options for severe aortic stenosis, including the protected TAVR, and the importance of getting your continued care during COVID. I am Andrea Baer, and I will be the moderator for the day. I am the Executive Director of Mended Hearts. Before we get started into the presentation, I just want to give a couple of housekeeping notes. All attendees are in listen-only mode, but to ask questions, you can, at any time during the presentation, type into the chat box, and we will get to the questions at the end of the presentation. But the great thing about that is you can put the question in at any time. You don't have to wait until the end. If you can't hear me right now, hopefully you can see the slide, but I'm going to ask you to check the audio button on your personal computer to ensure your sound is on and the volume is turned up. That's typically the biggest problem that we have when you aren't able to hear the presenters. Please type your questions into the question and answer box, as I said, and we will read those questions to the panelists at the end of the presentation. Finally, a PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. It typically takes 24 to 48 hours for it to get edited and put up. And so you can guarantee by the end of, probably at the end of the day tomorrow, we will have the recording and everything up on the website. So I'd like to introduce our panel today. We have Dr. Carlos Sanchez from Ohio Health at Riverside Methodist Hospital, as well as Ilea Reichert from the same hospital, which is amazing. I know you guys work together, and so this is going to be great. You guys, I will turn it over to you, Carlos, first, and then you guys can go on. Thank you. Carlos?
Thank you very much, Andrea. Hey guys, super excited to be here with Ilea to share some of our experience with you about transcatheter aortic valve replacement, and also about protected TAVR, is how we protect your brain from a stroke when we perform this type of procedure. So super excited to be here, and thank you for having us. Go ahead, next slide. So the heart is a very complex structure. As you may imagine, you can see that there are 4 major chambers, and there are also 4 major heart valves. The one that we're going to talk about today is the aortic valve. It's the one that points out at 12 o'clock, as you can see on the picture. That controls the flow that comes out of your heart to the rest of the body. Goes through the big aorta, if you've heard about that big aorta. Next slide, please. What we need to know about aortic stenosis is that it is not an infrequent medical condition. About 1.5 million people in the US have aortic stenosis, and about 1/3 of those have a severe condition. Oftentimes patients are not aware of this disease just because it's such a slowly progressive condition that by the time they realize they have a problem is already late, and they're very symptomatic in the hospital. So it's important that you always have your family doctor listen to your heart for any murmurs. Next slide, please. And so the aortic valve, as you can see on the left side, is a one-way valve that opens and closes. When it's healthy, it's a very nice thin leaflet. And as you can see to the right side, the picture depicts that it is calcified and thick, creating a narrowing, which is what later becomes aortic stenosis. And so the one-way valve now has a lot of difficulty opening and closing to get the blood flow out of the heart. So the incidence of this condition increases with age. As you continue to age, the higher the risk of developing aortic stenosis, and that's part of the wear and tear of your heart valve, particularly among people over 65 years of age, there is a lot of deposition of calcium, protein, and a lot of substances that over time make the valve become very thick and calcified, restricting its mobility. The disease, as I was mentioning, is very progressive and gradual. And, and that's the tricky part about this disease, that people don't really realize they have it until it's late. And it's such a slowly progressive disease that people tend to blame aging more so than the disease itself. It's not like a heart attack that, you have it, we were fine one day and the next day you're having a lot of chest pain. No, this one is so gradual that people don't realize that they have it. Next slide, please. So what symptoms can this condition give you or present with? Fatigue is the very initial symptom. Patients start feeling a little more fatigue, and this is when patients start blaming, oh, I'm just aging, especially those in their 80s and 90s. They come to the office and say, well, I'm just a little old. I think I'm just aging, but it's not. This disease will make you feel that way, but it will be the culprit of your symptoms. Then it progresses to more shortness of breath. That's when it becomes more apparent to patients, like something's not right. But it's such a slowly progressive disease that patients typically still are skeptical about what's going on. Then you start seeing congestive heart failure symptoms, what you call CHF. You have lower extremity swelling. You oftentimes may have some chest pain. And a really bad symptom of this condition is that you pass out. When you pass out from this disease, means that the blood flow that goes to the brain is lacking, and so that it's a high risk features for sudden cardiac death as well. So the mortality at 1 year once you get severe aortic stenosis is about 25%. If you let it go at 2 years, it's about 50%. So if you put those numbers in perspective, a mortality at 50% is much worse than cancer, many cancers. And so the only difference is that aortic stenosis is completely treatable. Next, please. And so what options do we have to treat these conditions? We have two. Transcatheter aortic valve replacement, or TAVR, TAVR, was approved, FDA approved for the first time in the United States in 2011. Prior to that, we had research studies and finally FDA approval that led to this technology to be for everyone that presented with the condition. As you may imagine, before then, and this is just 10 years ago, people who would come with aortic stenosis or present to the hospital with aortic stenosis would have a high mortality. They wouldn't have an option. They couldn't undergo open heart surgery because of their high mortality, so they would eventually die from this condition just because there was nothing else to do. And so it is a game changer. It has been since its approval in 2011. It has changed the landscape in how we treat aortic valve disease. And now we can treat essentially anyone with this condition, unless you're very sick in the late stages of your life. But surgery still plays a role. Surgery is open heart surgery, and there is also an option, but everything is moving towards transcatheter aortic valve replacement, as I'll explain why that is. Next slide, please. And so why transcatheter aortic valve replacement? Less invasive options. By far, this is a minimally invasive catheter-based option. That means that you have a very small catheter that goes oftentimes through one of your groins. It's an artery that runs through your groin and through the leg. And you go up to the heart and deploy the valve. We do it under conscious sedation nowadays. So you are essentially awake, sleepy during the procedure, and with very minimal pain. We use a lot of local anesthesia, a lot of lidocaine, and we use some sedation just to make you comfortable. But it is a very minimally invasive procedure that makes a recovery time to be very short. In about 70-80% of or even more than that, patients go home the next day without any problems, and they can resume their activities almost right away. It's about 3 to 7 days before they can essentially do anything they want. So that's the main difference compared to open heart surgery, obviously, which you spend a lot of time and recovery time in the hospital and home respectively. Next slide, please. So what risks are there for transcatheter aortic valve replacement? There are some minimal risks. Need for permanent pacemaker perhaps is an important one. The risk of pacemaker is anywhere between 6 to 10%, and this is based on whatever landmark trial you wanna compare. The low risk trial TAVR had a pacemaker rate of about 6% with a sapien valve. That is almost as low as open heart surgery. Vascular complications is another complication, just because we put the catheter through one of the vessels in the groin, like I explained earlier. Abnormal heart rhythms that lead to pacemaker. Then kidney failure, very rare. Valve leakage, very rare nowadays. The technologies have dramatically improved, like I said, and all these risks have gone down dramatically. Then there's death and stroke. And typically death is less than 1% with this type of technology. And then stroke, which is what we're going to talk about, how to prevent that. Next slide, please. And so the stroke risk. So during the valve replacement, as I explained earlier, the valve accumulates a lot of calcium and thickness and particles, essentially junk that it's really just hanging in the valve. So when you go in and put the TAVR valve, you're essentially pushing to the side the old valve. And so a lot of debris and pieces of calcium may dislodge and essentially fly and travel to the brain, leading to strokes. Now, this can be very inconsequential strokes, minimal strokes with minimal symptoms, or a very large stroke with catastrophic complications. Next slide, please. So what is the numbers or the post-TAVR stroke? So threefold increase in hospital mortality. If you have a stroke, you have threefold chances of dying. Over 100% increase in going to a skilled nursing facility or any other type of care facility. That's very important, especially nowadays with COVID. If you can go home, we prefer that much more than going to another facility. A 32% increase in the cost of index hospitalization, so your hospitalization becomes higher, and 132% increase in the cost of rehospitalization. It's not just about the procedure itself, but chances are you're going to be readmitted to the hospital within the next month or two with complications related to a stroke you had from the procedure. So it is costly, there is mortality, and there is morbidity. And the most important thing to understand about the stroke is, when we talk about stroke is typically what you hear on the news, on TV. It's the major catastrophic stroke. But no, what you're hearing about is essentially the tip of the iceberg. That's what you see. What you don't see and don't hear about is the big picture, everything that it's underneath the tip of the iceberg. The thickness, which is, you have micro strokes, and what's the consequences of micro strokes? Where there are consequences, there is cognitive decline. You may develop some confusion. You may develop some dementia changes down the road. We don't know, and that's why even subtle findings of strokes are very important to us. And we're trying to avoid and prevent every single stroke, not just the major one, but also the minor non-disabling one. Next one, please. And so the bottom line is that the strokes really have been unchanged since TAVR was approved, right? We've improved the technologies to dramatically improve other risk factors, such as pacemakers, such as PVL or leakiness around the valve, but really stroke hasn't really changed. And we've been trying to battle this for all these years, trying to find solutions, especially because of the problems that I mentioned of, going to nursing home, cost, mortality that happen with it. So the majority of TAVR patients likely have silent brain infarcts. And the question is, how do we prevent that? Next slide, please. And so we have a way to do it now. And for the last couple years, this type of device or filter was approved by the FDA to use in every patient that undergoes TAVR. We call it generically cerebral protection system, or CPS. The commercial system is called Sentinel. And so far is the only one, the first one and only device that is approved, FDA approved, to help reduce the risk of stroke during TAVR. And essentially it's a filter that you position in all the vessels, especially the arteries that go up to the brain. So you're protecting about 80% of the blood flow circulation that goes to the brain. And it will capture and remove every single debris, even the tiny little ones or the big ones that dislodge during the TAVR procedure. Next slide, please. And so this is an animation for you guys to watch and see how this is positioned in your brain. So go ahead and play it, please. And so that's the filter that was seen on the previous picture. And it's very intuitive.
A temporary protection device is placed in the bloodstream between the heart and the brain during the TAVR procedure, and then removed at the end of the procedure.
Thank you. So it's important for you guys to know that there is a way to prevent stroke during TAVRs. And if you have friends, family members that have aortic stenosis and will undergo this procedure, it's very important that you ask your doctor if they use the filter to protect the brain during the procedure. I think it's something that needs awareness in the community, and of course, as a physician, what you want to do is do everything you can to mitigate any possible risk when you do this type of procedure. So it's very important. And I'll show you what we've caught in some of our patients. So you'll see a series of pictures with different type of debris. And you can see that it goes from a tiny one to a lot of it to big chunks of debris that, yeah, maybe patients wouldn't die from this small amount of debris, but who knows? Who wants this type of junk or pieces of calcium clot in your brain? Perhaps it goes to where your memory is, and you start losing your memory from this. So we use it. I think our risk of, and Ilya will talk about it, of stroke has gone dramatically down from using this type of cerebral protection system. Next. I think Ilya, who is our lead nurse practitioner and leads the clinic, her work with this program has been dramatic, and she has improved the program to a level that we are grateful for. So she's going to be talking to you about patient perspective.
Well, thank you very much. Hello, everyone. It's a pleasure to speak with you today. Thank you to the Mended Hearts organization, as well as Boston Scientific, for allowing me this opportunity. And thank you, Dr. Sanchez, for those kind words. I get the privilege of talking to patients and family members just like yourselves on a daily basis in our structural heart clinic. And, some patients come in and they're very well educated on their disease process. They are they know about their disease, they know about treatment options, and they've even attended a webinar or two, maybe on Mended Hearts. Other patients come in and this is brand new information to them and it's very overwhelming. But either way, there is a spectrum where patients fall. And on that spectrum, I see lots of patient questions and even hesitancies moving forward with valve replacement, and there's a common theme no matter where they fall. And so I thought I would use this platform to kind of address some of those, because I think that they're common enough that people who maybe haven't met with a structural heart team yet maybe would like to get those clarified as well. So I don't have a couple of slides on them. So instead you get to see one of my coworkers, Anne. It's actually a photo that I think she's expecting some royalties from that I've used. But 3 common questions or hesitancies that I hear about. So the first one, and a lot of this piggybacks off of what Dr. Sanchez was just talking about. The first one being, I don't really feel all that bad. Yes, I'm slowing down. Yes, I'm getting a little bit more short of breath with some of my activities that I normally don't get short of breath with. Maybe I'm starting to get a little bit more swelling in my legs. Now, don't get me wrong, there are some patients that we meet who are very symptomatic. They are very short of breath. They've had repeat hospitalizations for heart failure. They have significant swelling in their legs. Some of them are not even able to get up and cross to the room without getting extremely short of breath. And I'm not talking about those, because those patients will sign up for a valve replacement tomorrow if we allow them to. But for the patients who maybe their symptoms are just starting to impact their life, it bears repeating to them that this is a progressive disease. Aortic stenosis will continue to get worse, and heart failure symptoms will continue to worsen, and eventually it could or will lead to your death, just like the statistics that Dr. Sanchez talked about. Being unable to breathe, which is what heart failure is a very scary symptom, and it's one that we don't want any of our patients to have to live with longer than they have to. So some patients say, well, I want to wait until my symptoms get a little bit worse before I proceed with valve replacement. And to that, I say, we want patients at their absolute best before they undergo any procedure. And I think any surgeon, any physician would agree with that as well. We want patients who have a severely narrowed valve, who begin to have symptoms, to undergo their procedure when they are well and functional. We want our patients to walk into their procedure one day and walk out of the hospital the next. I have many, many patients tell me on follow-up after their valve replacement, I didn't realize how bad I felt until I felt really well again. So that's the first hesitancy that I hear. The second is, again, it's my age. I'm 85. How much better could I potentially feel? I'm never going to feel like I'm 25 again. And I'm sure you've all heard the age-old adage that age is just a number, but when it comes to TAVR, it's absolutely true. We have performed TAVR in very young people, even in their 40s, 50s, and up into people in their hundreds. That's in their hundreds. If you are functional, if you are independent, we want to keep you that way. We want to make you feel as good as you can for as long as you can. I actually read an article once on a little lady who was 103 who underwent TAVR. And afterwards, she said, I feel like I'm 75 again. She was so happy with her results. The goal is not to turn back time, it's to give you quality time, right? We want to keep you out of the hospital and feeling good and doing what you want to do for as long as possible. And finally, the third hesitancy that I hear, and it's probably most relevant to our topic here today, and this is almost verbatim what I hear from patients, is I am not afraid to die, but I am afraid to have a stroke. I am terrified of being a burden to my family. And it's extremely common, and it's one that we take very, very seriously. For those people who are independent, the thought of losing that independence and being dependent on other people, the thought of developing dementia and having to leave their home environment or having to be a burden to their family is a significant one, and it should be one that is taken very, very seriously. Now, as you'll see on the next slide, this is obviously not a new concern. This is a concern that physicians have been hearing since TAVR was instituted. The question of what is the biggest concern for your patients that you're hearing about was presented to a group of physicians at a medical conference, and nearly 70% noted stroke as the biggest concern that they had. And when asked if cerebral protection, that sentinel device used to protect against stroke, should be necessary during TAVR, 80% said yes, at least in some select patients. Now, the problem is that there's not a clear way to decipher who's going to have a stroke when they are undergoing their TAVR procedure. There are some high-risk features that have been, kind of studied upon: people with atrial fibrillation, narrowed blood vessels, patients who've had prior strokes. But any structural heart program who performs this TAVR will tell you that they have seen a younger patient without these features who have had a stroke, and it was devastating to watch. So Dr. Sanchez discussed what debris has been found in these sentinel devices, and it's lots of different things. It's valve tissues, it's calcification, among others. As we see on the next slide, what we also know about TAVR, and this is again kind of reiteration what Dr. Sanchez said, is that patients who have strokes after TAVR go home less often, meaning that they have a prolonged hospital stay, much longer than we anticipate. They go to inpatient rehabilitation or a nursing home or living with extended family, and that one's pretty rare if they need a lot of assistance. And they're not going back to their way of life. And the truth of the matter is we don't know if they'll ever return to that level of life. We also know that a prolonged hospitalization and nursing home costs, this drive up individual costs as well as hospital costs. And even minor strokes. Dr. Sanchez touched base on silent strokes. What is a silent stroke? Well, that's, you don't have weakness per se. You don't have any difficulty speaking like what we hear about in the media. But if we did an MRI on you, we would see that there are these tiny little strokes. And what we know about those silent strokes is that those can actually lead to cognitive decline and dementia sooner rather than later in some of our patients. And again, it's that loss of functional status. And this is absolutely, whether big or small, stroke is devastating to patients and families. Now, I love this part of my discussion with my patients where I get to show them how our program does everything we can to reduce this risk. We implant cerebral embolic protection with the Sentinel device in every patient who we can. The only reason we wouldn't is due to a patient's anatomy, which we would pretty much know beforehand. Placing this device really adds minimal time to the procedure. Dr. Sanchez says it's pretty easy to implant, and it comes with very minimal complications afterward, the most being some minor bleeding at the wrist. But most patients don't even know that it was placed or even that they had it in. We take stroke risk very seriously. I think every physician and program that offers TAVR or even valve replacement should be taking stroke risk seriously as well. And I hope after today and after today's talk that at least you feel empowered to have these frank discussions with your team regarding what measures they're doing to reduce stroke risk. And lastly, I want to speak briefly on the hesitancy of proceeding with TAVR given our current clinical status with COVID, the COVID-19 pandemic. Boston Scientific recently reported that nearly 80% of patients with severe aortic stenosis were nervous about their in-person doctor visits, and 70% reported that they were seeing or talking to their physicians less frequently. Unfortunately, as Dr. Sanchez discussed, aortic stenosis is a progressive disease. It does not wait for a vaccine. It doesn't wait for an election. It's only going to get worse. Some patients may not have symptoms today, but they may a month from now or 2 weeks from now. Many will be hospitalized unnecessarily, and we've already seen this, out of fear of coming into the hospital in the first place. I hope that I can give you some reassurance. Now, I don't speak for every hospital system, but I do know that the medical community at large is taking every possible step to reduce the transmission of COVID-19 in their facilities. At least I know we are. I think that you should talk with your medical team about when and how to proceed with your valve replacement. And patients, trust me when I say that patients will not be undergoing any unnecessary testing or treatments unless they really need it. I even want to talk to you about what you can kind of expect, because I've heard from a lot of patients, oh, I didn't expect you to look like this. So I wanted to kind of, if you haven't been in a hospital setting or in an office setting recently, expect that we're going to have visitor restrictions in place. You're not going to have all of your family members come into the hospital to see you, no matter what you're having done. Everyone will be wearing a mask, and you will be expected to wear one as well, even during your hospital stay. If you're up walking around in the halls, you'll be expected to wear a mask as well. I even have mine. That is to protect other people. Providers themselves may be wearing things like goggles, and what I think is a lot of takes people back a lot are these face shields. So many providers are expected to wear these when we come into contact with you. This is just to protect us and as we go to patient to patient to patient. So expect that your providers are going to look a little bit different when you do see them. And lastly, you may be required to get a COVID test before your procedure. In fact, you may be required to get more than one COVID test, but understand that that is, again, for the protection of the community at large. If you are positive and not having symptoms, don't worry, you will be rescheduled. It's not going to be a huge delay in getting you treatment, especially if you're symptomatic. But trust in your team, ask important questions, feel empowered. And, we are constantly learning and adjusting as a medical community to what this virus is about. And we are committed to keeping you all safe. Now, I know I could continue to speak on behalf of patients' perspectives, but I'm sure you'd rather hear from a patient who's kind of been there and done that themselves. So it is my pleasure to introduce Jim McCutcheon.
Good afternoon. I'm a 90-year-old retired physician. I retired 13 years ago. When I was 77, I was a urologist, not a cardiologist. Anyhow, I knew I had aortic stenosis, but it didn't bother me. It was just a heart murmur. That was until Bob Madry, my cardiologist, said, Jim, your latest echocardiogram, I was having one every 6 months, showed you've gone from moderate to severe. You need to start looking at treatment options. Well, I knew what the treatment options were. Open surgery, TAVR, and death. I didn't have to research death, and I didn't have to research open surgery. I knew what that was about. I had that. What I did have to research was TAVR, and what I found out was two critical things, and they've been mentioned. One of them was the death rate, which in my reading said 50% once it became symptomatic at 3 years. Dr. Sanchez has said at 2 years. Those are different studies. Both numbers are valid. You can use what you like. Anyhow, the other critical thing was all the discussion about stroke. So I started reading about stroke after TAVR. And what I found out there was that there was a device, a sentinel device that was in use in Europe, had been in use for 2 years, and the statistics out of Europe looked very, very good. I always look at a risk-reward ratio, and the risk of the sentinel device is essentially zero, and the reward is phenomenal. So I said, okay, I don't have any symptoms. I'll wait. I want to wait until the sentinel device becomes available. I began to get symptoms. I didn't get all of the symptoms that have been mentioned here, but I did get shortness of breath, which was fairly severe. I was playing tennis with a bunch of guys in their 60s, and I'm in my 80s, and I'm unable to run without stopping to bend over, gasp for breath. And one of my friends said, if you die on the tennis court, I'm going to kill you. So anyhow, I'm symptomatic. The clock is running because that's when it starts to run. And I have either 2 years or 3 years, depending on the studies, before I'm 50% chance of being dead. So I was looking at this study that was mandated, and it was ongoing here in this country, and the sentinel would not be approved until that study was reviewed and approved. There were 3 principal investigators. One was in Leipzig. I'm not going to go to Leipzig. One was in New York. One was in Cleveland. I found on the Cleveland Clinic website, info at Cleveland Clinic. I didn't know the name of the principal investigator, but I knew he was there at the Cleveland Clinic. So I sent a generic email. Can somebody tell me how long this trial is going to last. Within 48 hours, I got a 7-word answer, at least a year and a half. And at the bottom of it, there was a word I didn't recognize. It was spelled S-A-M-I-R. I thought, what the heck is S-A-M-I-R? I'm sure Dr. Sanchez knows who that is. It's the first name of Samir Kapadia, who's the chief of interventional cardiology at the Cleveland Clinic. Well, I decided I would wait some more. Yeah, I was short of breath, but I didn't have to play tennis. I quit. I didn't have chest pain. I didn't have congestive heart failure. I figured I had better odds than 50% of surviving until the sentinel came online. I happened to run into Samir Kapadia at a meeting, and I introduced myself, and he remembered me, that I had emailed him. And I told him, I'm going to come to see you when the sentinel is approved. He said, you'll be my first patient. I took that with a grain of salt. The guy's done 1,000 of them already, and I'm sure he has multiple people in the pipeline. I won't be his first patient. Well, I got word around 5 o'clock on a Friday that the FDA had granted approval for the use of the sentinel procedure. At 9 o'clock on Monday, I've got a phone call. This is Dr. Kapadia's nurse. I have your appointment ready. So I went to Cleveland, met him again, talked to him, visited with him, found him to be a very, very compassionate human being, like Dr. Sanchez. And I had some more studies, preliminary studies, and I went home and came back. I had the procedure in 2017, it's September 2017, almost exactly to the day 3 years ago. I was 87 at the time. It was a piece of cake. I had the procedure on Wednesday. They kept me in the hospital on Thursday. I went to the hotel on Friday and flew home on Saturday. So how's my life after that? It's great. I do my own yard. I dig in the dirt. I've even driven up to College Station to spend 5 days helping my son build fence for my granddaughter to train her Mustangs. And no pain, no trouble, no shortness of breath. Yeah, fatigue, but you're supposed to get fatigue when you're 90. I'm very happy. I have not looked back except for 2 things. I've looked back to thank Samir Kapadia, and I've looked back to thank the people who developed the sentinel valve, sentinel cerebral embolic protection system. That's it.
Thank you so much. That was great to hear your story. We appreciate you sharing it with us. So thank you all 3 for giving us some great information about the Sentinel device. We will open for questions. We have some time to take some questions from the audience. I already have a few, so I will start with them. But just as a reminder, if you have a question, you can type it into the chat box and we will read them from there. I'm going to open the chat box while you're answering the first question. And the first question is, what if my doctor says that this is not available? What can I do?
I'm sorry, you broke down, Andrea.
I'm sorry.
Okay, I'll answer it.
Okay.
You can find a lot of information online, and you can read, you can find out where it is available, and you can go there. That's what I did.
That's great advice. That's great advice. And I guess the other one is, what if it is not covered by insurance? Or is it always covered by insurance?
That's a good question. So it is the majority of the time now is covered by your insurance. We've had some challenges, especially in the low risk population. You know, when the trials were approved by the FDA, they were approved, and I'll provide a very brief history about it. When we started the TAVR trials, we started it in patients who had no options, who had no surgical options. So either you would bring patients very sick with aortic stenosis, very, very sick, and you would ask them, hey, listen, you're going to die from this condition, and this is an investigational device. This is your only chance. You have a 50% chance of getting the valve or nothing. Those who got the valve survived, had almost a 30 to 50% improved mortality over those who didn't get anything. So from that point on, we moved to the high risk cohort of patients, and then to the moderate risk, and then to the low risk. And for the last decade, you know, we've been, you know, just chasing those trials with FDA approval. And it wasn't until recently, last year, that we approved the low risk cohort. So some insurance companies are lagging behind. And in fact, the low risk cohort of patients with severe aortic stenosis that we offer TAVR oftentimes get denied because they think that it's not approved for that indication yet. But it is. Now it's approved for everyone. However, you know, that there is a subset of patients that we still recommend surgery as the first option, and that's based on different factors and longevity and other things that we tend to consider.
Andrew, was the question for insurance approval for TAVR and cerebral embolic protection? Do you know which it was?
Yeah, I think it was just for the sentinel device, for the cerebral protection device. But I guess
we have not. They do, and we've not had any insurance denials for that, to my knowledge. Like Dr. Sanchez said, I mean, we have had some for the low risk population for the TAVR device, but we also will do peer-to-peer and lots of other things kind of behind the scenes for the patient on behalf of the patient.
Great. Okay, so the next question, I think I know the answer, but I'm going to just ask as a clarification. The device is not kept in there. Is that correct? Is it removed? Because the question is, does it keep helping after the TAVR? But the device is removed. Is that correct?
Correct. It is removed right after we finalize the procedure, just because the device goes through your wrist, through the artery of the wrist, and obviously we wouldn't be able to leave it in forever. So there is a catheter that it's sticking out from all the way from the brain to the wrist.
Excellent. So the next question is for Jim. Does it help to talk to other patients, or would you have liked to have talked to another patient about this prior to having it done?
I did talk to another patient. I had a good friend, Alicia Pettis, who had the procedure done here in Corpus Christi the same day I had it done in Cleveland. And she was lucky. She didn't have any strokes. And it's 3 years now, and she has not had any dementia. So wonderful. It can be done locally, but I don't think it should be done without cerebral protection. And Alicia decided she didn't want to go out of town. She had it done, she got away with it. I'd call that good luck. I don't call that being smart.
Yeah, absolutely. Absolutely. And so this question is kind of a follow-up to one of the beginning ones. And are most hospitals now and valve clinics using the Sentinel device, or is it very few since it's such a new technology? Do you know?
I think it's half and half. I don't know the exact statistics across the country, but no, it's not every hospital. It's not every hospital, especially I think from because of the reimbursement aspect that plays a big role, I think, in many institutions. So now the percentage, I think it's about half of the country who's using it, maybe a little less than that.
I believe on the website, and I could be wrong, but I believe on the website you can actually Google which where there is a Sentinel program who offers that near you.
Can I say something about that? I was very gratified to learn that when it was approved, it was not rolled out all over the country. Boston Scientific didn't own it at that time. Claret Medical owned it, but they would only approve using it after they had gone into the community and trained the cardiologists to use it. And I thought that was very responsible. Apparently you're still doing that at Boston?
They do. They support, if you have a TAVR program and you want to start using cerebral protection, they will support you and go through the appropriate training prior to implanting one of these devices.
That's very comforting to me, and I think it would be very comforting to any patient who is looking at having it done.
Right. Right. Here's another question, which is a great one. Does it make the TAVR last longer?
Not really. There is a learning curve to implant and learn this procedure. As we've been doing it now, I think over a year, it takes me personally 3 to 5 minutes to implant. So, if you want to prevent a stroke, trading off 3 to 5 minutes of extra time of procedure, it's would be crazy on.
Yeah, for sure. Great. Okay, so I have come to the end that are all written down now. So I will put out another last call for any questions. If Carlos, if you or Ilea have any questions for Jim, feel free to ask those at this point. And while anybody else is taking some time to put in their questions.
I guess I would ask Jim, what do you wish you were told by your heart valve team before going into this procedure? Is it more reassurance? Is it, what do you wish you would have known?
I didn't need anybody to tell me anything. I had done my own research. And so I was familiar with what was going to be done and what the complications are, what the risks are. I didn't need any counseling. But I think the service that you are providing to patients prior to the procedure, people who are not doctors, who are not have not done the research, it's extremely valuable because studies have shown long ago that patients who go into surgery, whether it's transcatheter surgery or open surgery, they do a lot better when they know what to expect and have been reassured.
Yeah, absolutely, Jim. And I think that's really important. And one of the goals of Mended Heart's TAVR program, we have a visiting program where we actually can match patients with people who have had a TAVR. And so prior to them getting the TAVR, they can ask questions. And we find that a lot of people are comforted knowing what to expect during and after the TAVR from that patient perspective. So I do think it's really important. And Ilea, I would just piggyback on that and say, as a valve clinic coordinator, I love that you all give so much great education and information. But I think sometimes that just saying, would you like to talk to somebody who's been there is always a great idea to make sure that they're comforted on that emotional level from another patient who's been through it.
Yeah, that's a great idea. Jim, can I have your phone number after this?
Yeah, I want Jim's phone number too. If we're going to get him to talk to people.
You're going to send people to see me?
Yeah.
All right.
I don't have a license anymore. I can't do that. So I can do counseling.
Well, you can be a counselor. You don't have to be the doctor.
Yeah, I don't have to be licensed for that.
Yeah. All right, a couple of just ending notes. The center finder is on the Treat the Heart website. So the website link is www.treattheheart.com. And you can find out if there's a center near you that does have the Sentinel and uses it. If you have any questions relating to this webinar or any of our other webinars that we put on, or you would like to join us, you can find us at www.mendedhearts.org. I have placed my email here. If you have any questions or you think of something after the event and you would like to have the question answered, you can email me. We would like to thank Boston Scientific for supporting this webinar and the great information, as well as taking care of the patients with the Sentinel device and with the TAVR. So seeing no other questions, I believe that we are going to be finished for the day. So thank you all so much for joining us. Dr. Sanchez and Ilea and Jem, thank you all so much for joining and spending some time with us. We truly appreciate it.
Thank you.
Thank you, and everybody have a great day.
Bye.
Bye.
Bye. Thank you.